Hi, Ashish. Hi, Ashish and Amit.
Welcome, Dr. Atin.
Good evening, sir.
Hi,
How are you?
welcome. I am Dr. Karthik Nagesh. Welcome, Tin. Thank you for joining us.
Dr.
Thank you so
Karthik,
much, sir,
आपकी
for
आवाज
the
नहीं आ रही.
opportunity. Thank you.
Dr. Karthik, you are not audible.
Not audible, is it?
No, no, no. Amit, can you hear Dr. Karthik?
No, no, sir. I can't hear right now.
He is this fellow there, Vidhan. I have been trying to ring him. मेरा फोन तो उठाए. डॉक्टर कार्तिक फिर से बोलो आप.
Can you hear me better now?
Yes, yes. Now you are audible, sir.
Great. Thank you, Amit and Ashish, for inviting me, and thank you, Atin, for joining.
Thank you, sir.
Wonderful. Welcome to our Neonatal Forum.
Thank you, sir. Thank you very much. It's really wonderful to have you, radiologists, which who are our best friends.
Dr. Atin,
It's,
Dr. Karthik is virtually the pioneer of neonatology in South India.
Oh my God, don't embarrass me. But anyway, just to give
he
you a background, hmm.
he visited AIMS NICU. He wasn't too impressed, so he went to UK instead to train in neonatology. Is that right,
I
Doctor?
was a, yeah, I was a pool officer in AIMS NICU, Atin. Ashish knows me from then.
Sir. The tech team, can we switch on our videos before we start so that we can see each other face to face? Is it possible? It says we don't have permission to start the video.
Let me ring up this fellow technical person.
host has disabled it.
Yeah, the
ऐसा
host has
कैसे होता
disabled the video. Yeah.
भाई अमित,
हाँ सर.
अरे भैया विधान जी का फोन तुम मिलाओ, हमें अलाउ
मैं
तो
कर रहा
करो.
हूँ. मैं कर रहा हूँ सर. देखता हूँ.
Welcome, Dr. Manisha.
Thank you, sir. Good
I
evening.
hope
Welcome,
I
Dr.
hope you are
Manisha.
out of your viral blues, or is it still bothering you?
No, just a bit of cough. Otherwise, I'm fine.
Thank you so much for bearing with us.
Thank you so much, Manisha, for coming and joining us. Really very nice to have you and Atin here. I'm Dr. Karthik Nagesh. I'm at Manipal Hospital, Bangalore.
The
So,
pleasure is completely mine, sir.
Sir, I just saw the flyer.
Yes, sir.
I think probably it was our mistake. Manisha is not an associate professor. She's
He's
also,
a professor. Sir,
yeah,
I
she's a
realized
professor
that.
with
I
me.
thought I will correct it here. I am so sorry.
No, no
I,
problem. I didn't realize earlier. Manisha is also professor with me. Same.
हाँ हाँ जी हाँ जी सर मैंने देख लिया it was too late to change in the
हाँ
flyer.
हाँ सर.
Dr. Manisha, I am extremely sorry, but that is I will.
That's perfectly fine, sir.
But Dr. Karthik, you have the current designation for the intro, isn't it? You have the current designation with you.
Yes, yes. We know Professor Manisha is a full professor. I know that.
Yes, yes, yes.
Yeah. Dr. Ashish and Amit, I'll first introduce Dr. Mangala Bharti, who will join us very soon. And then he will introduce Professor Atin and Professor Manish. हाँ जी.
लिंक उसी में है, मैं दोबारा भेजता हूँ.
I have forwarded it.
वीडियो अभी भी ऑन नहीं हो रहा है.
No, sir. It says the host has to allow.
विधान
Dr. Karthik,
Yes, please. Please tell me.
सर मैं ये कह रहा था कि बिटवीन आप इंट्रोड्यूस कर देंगे फिर आप चैट बॉक्स में देखते रहेंगे क्वेश्चंस मॉडरेट करने के लिए ना क्विकली यू कैन स्कैन थ्रू व्हाट समवन इज आस्किंग राइट.
Definitely, I'll do that.
इसका हो नहीं यहाँ पे, क्या कनेक्टेड नहीं हो क्या? ये वीडियो ऑन नहीं हो रहा, सब लोग बात कर रहे हैं, तुम उस पे रिस्पॉन्ड.
वीडियो नहीं ऑन हो रहा बेटा.
भैया नहीं है, इसमें सब क्लिक कर रहे हैं, किसी का भी नहीं हो रहा. इसमें आ रहा है कि होस्ट इज डिसेबल्ड, होस्ट हैज स्टॉप्ड इट, यू कैन नॉट स्टार्ट योर वीडियो बिकॉज होस्ट हैज स्टॉप्ड इट.
Amit, I have got through to Vidhan. He is saying that he has assigned someone else. He is doing it in 2 minutes.
मैं नितिन से बात कर रहा हूँ. भाई नहीं हो रहा है, जब इतनी बात हो रही है तो उसको देखो क्या है पहले से. ओके, इतनी देर से लोग हैं इसके ऊपर, तुम्हें डायरेक्ट रहना चाहिए. लोग यही बोल रहे हैं, आप डायरेक्ट रहिए इसके अंदर, डायरेक्ट ऑन होके एकदम. पता नहीं क्या ऐसे कर रहे हो तुम.
Welcome, Professor Mangla Bharti. Mangla, can you hear us?
Yes, sir, I am here, sir. Good evening, everyone.
टीवी
Thanks.
नहीं आ रहा है
Professor Atin and Professor Jana, Professor Mangla Bharti is professor and head of Institute of Obstetrics and Gynecology and Institute of Child Health in Chennai. He's head of neonatology.
Good evening, sir.
Welcome,
Nice to meet you.
Dr.
Good
Bharti.
evening.
Welcome.
Well, hello, sir. Good evening, sir.
How are you?
Fine, sir. Doing fine, sir. It's nice to meet you, sir.
Is it raining cats and dogs in Chennai or is it cool?
No, very occasionally, sir. Some little monsoon rains every now and then, little bit.
You can take some
No
from
heavy
us.
rains.
You
Yes,
can
sir.
take some from us.
now it is there the video is enabled I think now
No, sir, it still
Me,
says.
it still says you can't start because host has stopped it. I don't know if it is for
I
me.
am able to put it on now but
आपका तो ऑन दिखाई दे रहा है पर हम सबका स्टॉप्ड है अभी भी.
am I visible on the because I'm not visible to myself as well.
You are not visible, though on the side panel it shows as if your video is on.
Hello, Dr. Ashish. Amit is already
Hello,
there.
Dr. Bish. Welcome,
Hi
welcome.
Dr. Surendra, welcome.
Hi, कैसे हैं आप?
Namaskar, Dr. Karthik here.
Hi, Dr. Karthik. कैसे बात कर रहे थे? I know you. मैं आपके पास ही आने वाला था. ठीक है.
Acha.
And कैसे हैं आप? I think videos have been disabled.
Yeah. Dr. Bish, is there a reason for you to come to Bangalore?
There are so many reasons for me to come to Bangalore. Only thing I am not able to come. I am not coming to Bangalore till you finish off your issues. I think Amit, जब तक आप लोग अपने issues पूरा कर लो. And we had made a team to do that. Let's see it happens. We will have a big thing over there in Bangalore.
Great.
I think we should.
Welcome.
I think we should come to Bangalore very fast.
Hi, Dr.
सर
Surendra.
ये
Atin here.
हाय अतिन में आ रहा था भाई वीडियो डिसेबल कर रखा है आई डोंट नो व्हाई वीडियो हैज बीन डिसेबल्ड
अरे आप लोगों ने
Somebody
कर
else.
रखा है, आप इनेबल ही नहीं कर रहे.
ये सब
कौन करेगा
न्यूरल
Host-
नेटवर्क्स की प्रॉब्लम है. डॉक्टर अतिन और डॉक्टर मनीषा ही एक्टिवेट करें.
नहीं कौन करेगा हु आर द होस्ट
अरे यार ये विधान तुम्हारे ऑफिस का जो है उसने पता नहीं क्या किया है
host, तो ये नेशनल न्यूरोलॉजी
एक मिनट दीजिए सर, एक मैं बस अभी कर रहा हूँ उसको.
क्या करा भैया विधान तुमने हाँ ये कौन सा नया
अरे
तरीका कर दिया इस बार
अरे नहीं मैंने नहीं किया सर. वो
एक कैन द पार्टिसिपेंट्स हियर अस नाउ?
Any of the
Yes,
participants?
sir. Yes, sir. They could always hear us.
Okay, so I'm just giving introduction and we will roll then, right?
Yes, Dr. Ashish.
Okay, welcome everyone to this evening session of New Music. And as I said, heard melodies are sweet, those unheard are sweeter. So every time in New Music we hear new melodies which were unheard earlier. Today we have got a galaxy of stars to introduce and take us through the whole gamut of neuroradiology in newborns. We have got Dr. Karthik Nagesh, who is the head and who's the group head of Manipal Hospitals for Neonatology. He's also professor of neonatology, Manipal University. And we have Dr. Mangla Bharti, who's professor of neonatology at Institute of Obs, Gynae and Pediatrics, Madras. And we have Professor Atin and we have Professor Manisha from All India Institute. Dr. Karthik, to please take over.
Thank you so much, Dr. Ashish. It's a wonderful privilege and pleasure to be chairing this session. Thank you, Dr. Bisht, and most thanks to Dr. Amit Upadhyay, my junior from Safdarjung Hospital, and I have pleasant memories of Safdarjung and All India Institute. Both of you belong to those institutions. So I have my pleasure of introducing Professor Mangla Bharti, who is a young dynamic neonatologist, my junior from my alma mater, PGI Chandigarh. So he is going to be taking the stage on trying to introduce Professor Atin, and we are really privileged to have Dr. Jana also. So Mangla, please go ahead, and then we'll take up the session. We'll reserve the questions for the discussions after the talk.
Thank you, sir. Can we have the intro slide of the speakers, please?
Dr. Bharti, you could introduce them.
Mangla, we don't have an introduction slide, but obviously we are aware of the excellent work done by Professor Atin in the field of pediatric neuroradiology. He is a pioneer in pediatric neuroradiology. And I'm just amazed. Of course, I don't have a slide here in front of me, but I know that he has more than about 250 publications of repute in various journals peer reviewed, and he's got about 35 chapters in books and all in the field of pediatric neuroradiology. He's a professor of radiology at All India Institute, Delhi, and he's had orations given the Sri Desi Bose oration of the IRIA and also the Gadekar oration of the ICRI. I mean, I can keep on going on his. I can extol more about him, but I think we're really privileged to have him. Thank you so much, Atin, for joining us. And at the same time, it's my proud privilege to introduce Dr. Manisha Jana. She's a young professor of radiology. We're really privileged to have her. And she's accomplished so much. She has had uh, 5 radiology textbooks to her credit, which she has edited. She has written about 63 chapters in book chapters in pediatric radiology, and she has been the recipient of many awards like the Dr. Satya Gupta Award and also the NAMS Award from the state of Punjab. She is also numerous publications, more than 215 publications internationally she has had. So we're really very privileged to have you. So over to Professor. The first talk I think will be delivered by Dr. Manisha Jana. Please, Professor Manisha Jana, please. Thank you.
Thank you, sir. I'm really humbled by the elaborate introduction. Without wasting any time, we'll for the next half an hour, I'll be discussing about the reading neonatal head CT, followed by Atin sir will be dealing about the MR. So first, just 1 or 2 slides about the basics of CT. I know this is not the domain of the neonatologists, but whenever we are learning something, it's always good if we have some ground knowledge, some basic knowledge about that modality. So CT, as we know, it is in today's practice, we cannot do without CT. Not even a single day we can go without having seen a single CT scan. So there are many positive, many pros of this entity. We can acquire the images really rapidly with good spatial resolution, and good reasonable amount of soft tissue contrast. The main disadvantage of CT is the radiation issue and need for contrast. So just to brief, how did the CT, the revolution, we'll, rather than evolution, we'll better call it a revolution, because it has changed the way we see inside the human body. So it's all started in the 70s with the beginning of computed tomography. Then it evolved into a spiral or helical CT, which is the main the which is the CT that we use today. Then came the multi-detector row CT, which made the CT scan acquisition much faster than previous. Then after that, in the early 2000s, we got the dual energy CT, which again added another dimension in the CT. So by dual energy CT, we tried to look into the material decomposition. What is the material? Is it blood? Is it iodine? And so on. So this is how the CT revolution started and went on. So there are several terms that we use day in and day out in CT, like helical CT. So helical CT is nothing but like the table rotates, as in this cartoon we can see that the patient is lying on the table, and this spiral thing is actually the gantry. So the gantry will be rotating and the patient will be moving inside the gantry. So this is the basic translation rotation motion that happens. So helical CT is like this. Earlier there was sequential CT where a patient will be advanced a little bit and there will be one section acquisition. So as that is called step and shoot type of acquisition. As we can easily understand that that would require much more time compared to this model, when simultaneously patient is moving inside the gantry and the gantry is also rotating. This amounts to a faster acquisition. Then came the multi-detector CT. So as on the left-hand panel, we can see a very thin rim of detector. To comparison, in the right-hand panel, we can see a wide range of detector. And the effect is very visible, a wider range of coverage. That means a very fast scan, a very fast acquisition of the scan. So the number of rows of detector varies from vendor to vendor, and the numbers just keep on increasing. Then in the hierarchy, we have dual energy CT, which can differentiate between different materials. And the latest lead on the block is photon counting CT, which is another advancement of a dual energy CT. Now, once we know about, so CT actually it uses X-ray radiation. So it is an ionizing radiation. It uses the basic principle, the basic of the core or the heart of the machine involves an X-ray tube, a very high, heavy-duty X-ray tube. So once we have acquired a CT scan, then comes how do we view them? These days, the viewing of CT scan on a film, it is coming down just because of the advantage that we get when we see the scan on a console. So we always prefer seeing the images on a console. Now here we use a few terms or jargons called windowing. Windowing is nothing in which light you want to see the scan. Like in the same image, I can play with the grayscale values and make the image appear very different. For example, this is the usual image that we get to see. This is what is called the brain window or the soft tissue window, in which we can see the gray matter and white matter differently. See here, we can see the white matter appearing a little more hypodense or low attenuation, and the cortex is appearing a little hyperdense or a little more white as compared to the white matter. So gray matter and white matter. This is how a normal routine brain window looks like. But when we play with the image in the console and we make the window or the viewing, it is through which we view the images, if we play with it and we can make it like this, in which the bones are better visualized. This is called the bone window. In this window, we are not supposed to look at the parenchyma. Rather, we are supposed to look into the bony details, the bony cortices, whether there is any fracture or not, whether there is any other bony abnormality or not, but not on the parenchyma, because as we see in the background, the brain parenchyma is all gray. We cannot see the details. These two are the basic windows that we use in routine reading. However, there are a few more two more windows that we have to use sometimes. This is called stroke window, in which the contrast is much exaggerated so as to make the difference between the gray and white matter much more stark. Here we can see it is appearing very grainy, very inhomogeneous. But this inhomogeneity, it exaggerates the difference between the gray and white matter, and a small subtle infarct is much well visualized in this window. This is yet another window which is called the subdural window, where a small subdural, as we see that a very small lesion, here it is a venous sinus, but any lesion which is adjacent to the bone, they won't be very much well visualized on a routine window. But if we make the window a little wider, that means more number of gray pixels are being counted. So the number of grays, like from 0 to say 100, if it is routinely, and when we are using the subdural window, it is much more widened. So it becomes like 300. So this is called the subdural window. It is better for the subdural, the extraaxial fluid collections. So this is how we look at the scans. Now, here comes the question, why and when to give the contrast, NCCT versus contrast enhanced CT. So the left-handed panel shows the indications of non-contrast CT head. If we are suspecting bleed in cases of trauma, suspected bony abnormalities, and congenital malformations, in those cases, we don't need to give contrast. And rather, in suspected bleed, if we give contrast, it will act as a confounding factor. We cannot say if it is an enhancing lesion or a bleed if we have done a contrast enhanced scan in a suspected bleed. So in suspected bleed, we would never advise CECT. Rather, NCCT will suffice and is better than CECT. However, when we are suspecting any meningitis, any kind of infection, suspected mass lesion, tumor, in those cases, we'll have to give contrast to see meningeal enhancement or enhancement pattern in the mass. Now a little about the normal anatomy. So if we start from the topmost section, so these are the axial sections in brain. Usually we routinely rely on CT on the axial sections. So here we can see there is definite asymmetry. We'll just ignore that for now. In the top sections of the brain, we can see this triangular structure posteriorly is the superior sagittal sinus in cross section. In the middle, we can see that, hope my cursor is visible. In the middle, we can see this is the interhemispheric fissure. Now we have to divide the brain into lobes, frontal and parietal. For that, we need to identify the central sulcus. How do we identify the central sulcus? It is the longest, deepest sulcus which reaches closest to the interhemispheric fissure or the fox. It has got typical this hand area or a bulge here in the precentral gyrus. It does not divide Whereas the fissure, the sulcus anterior to it, it divides into a T shape. So these are the points by which we determine what is the central sulcus, which one is the central sulcus. The gyrus that is anterior to it is called the precentral gyrus. The gyrus which is posterior to it is the postcentral gyrus. And anterior to it is the frontal lobe, posterior to it is the parietal lobe. Now coming one section caudal, we can see the interhemispheric fissure is in the midline. We can see the sulci and the gyri. This is the superior frontal gyrus. We can still see this prominent superior sagittal sinus in cross section. So it is where in this location we need to look for this empty delta sign, because it looks like a delta, right? It looks a triangular like a delta. So in cases of cerebral venous sinus thrombosis, we have to look in this area for the venous sinuses. If there is anything, black thing, any filling defect in it, that is called the empty delta sign. A little more caudal to the previous section, we can see this is the body of the lateral ventricles bilaterally. They are pretty symmetrical. If the cross section of the brain is symmetrical, the ventricles are supposed to be symmetrically placed. A little more caudal to it. Here we can see the frontal horns of the bilateral lateral ventricles. In the middle, there is a septum pellucidum. This V-shaped structure is the internal capsule. We can see this anterior limb, genu, and the posterior limb of the internal capsule. Anterior to the left of it is the caudate head, and this to the right of it lies the lentiform nucleus. Medially lies the thalamus. So this is how the basal ganglia is identified on an axial scan. On the right side, we can see that there is a small black hypodense lesion in the posterior limb of the internal capsule. So this appearance denotes a small infarct or a gliosis. Also, this is the insular cortex, which is outlined here. So deep to the insular cortex, we will see the external capsule and extreme capsule. These two bright structures over here, they are the internal cerebral vein. Two more sections caudal to the previous section. It shows these are the lateral ventricles, and they are communicating to the third ventricle via the foramen of Monro. The yellow arrows point towards the foramen of Monro, and this yellow arrow points towards the third ventricle. So this is how the third ventricle is seen, oriented like this. Laterally, we can see this typical appearance of the Sylvian cistern or the Sylvian fissure, on which we can see the middle cerebral arteries over here. So this is the typical appearance of the bilateral Sylvian fissures. Anteriorly, in the anterior interhemispheric cistern or anterior interhemispheric fissure, we can see the anterior cerebral arteries over here. A little more caudal, we can see this is the anterior interhemispheric fissure or cistern, and here we can see two anterior cerebral arteries. This red arrow points towards the optic chiasm. Posteriorly, this is here. Posteriorly, this is the brainstem, and around this perimesencephalic cistern. On the lateral aspects, we can still see the lower part of the Sylvian fissure. A little more caudal section shows the suprasellar cistern. This is the basilar artery. Just posterior to the basilar artery is the pons, the ventral convexity of the pons. Here we see the fourth ventricle, which is like a small crescent-shaped structure. To the lateral sides of the pons, we can see these are the CP angle cistern or cerebellopontine angle cisterns. We can see both temporal lobes on here. So this is in short how the anatomy looks like on a routine head CT. Now the measurements, for measurements, we take this lateral ventricle frontal horn width, or we can measure the ratio of the ventricles versus parenchyma. We can measure the third ventricle dimension on transverse, or we can measure the temporal horn. All these measurements are for hydrocephalus. Now, detection of abnormalities. And once we know how the normal structure looks like, it becomes easy to identify abnormalities. Although all said and done, in a neonatal head CT is extremely difficult to decipher what is abnormal from what is normal, because unmyelinated white matter. So unmyelinated white matter many a times mimic abnormality, whereas while it is normal. So for this, we need to train our eyes on seeing neonatal head CTs. Otherwise, many a times this distinction between normal and abnormality becomes blurred. Here, what we see, this is abnormal. So this outside, in the periphery, we can see this density is that of cortex. Cortex is inherently denser than the white matter. But in neonates, sometimes it becomes more so because the white matter is very hypodense. However, here it is definitely visible that this is an abnormal head CT scan. Now I'll be talking a little more about hypoxic ischemic encephalopathy. And I think sir also will show a more elaborate description on MRI. However, just to brief, what is the difference between the HIE patterns in preterm babies and term babies? We know that in preterm babies, the germinal matrix persists in the cortothalamic groove, whereas after 34 weeks, it usually regresses. So that's why we see the germinal matrix hemorrhages and germinal cysts in preterm babies before 34 weeks, not term babies. The watershed zone the vascular watershed zone is in the periventricular location in preterm babies, and that's why we see periventricular leukomalacia or PVL before 34 weeks, not after that. And cystic encephalomalacia or PVL, they are much more common in preterm. They are commoner in preterm babies, because in such an earlier age, the gliosis does not happen. It causes liquefaction and resorption of brain parenchyma. So it is replaced by cysts. So here are a few imaging appearances of hypoxic insult. So on this CT, NCCT, what do we see? We see, if we just for comparison, if we go back to a normal head CT, so this is how a normal head CT looks like. We will be able to see the difference between the cortex and white matter. So gray matter and white matter differentiation will be there, preserved. And see, the basal ganglia will be very uniformly homogeneous, a little hyperdense than the white matter. However, in this scan, if we see, what is strikingly abnormal is that the entire brain parenchyma is appearing very, very much hypodense. More so, the distinction between the cortex and the white matter, that is lost. So there is loss of cortex and gray matter, white matter distinction. This happens when there is edema within the brain parenchyma. So there is diffuse edema in the brain parenchyma, also involving the deep gray matter nuclei, the basal ganglia, and the thalami is relatively preserved. So that's why the thalamus is standing out in the background of a diffuse edema. This is another appearance, which is also known as white cerebellum sign, in which we can see that the cerebellum is appearing white, whereas the rest of supratentorial brain parenchyma, it is appearing dark. So this is what is known as white cerebellum sign. And white cerebellum sign and reversal sign simply indicates that the cortex and white matter difference, this distinction, that is reversed. So the cortex becomes much more hypodense and white matter becomes more hyperdense compared to the cortex. These two findings, they portend a poor prognosis in hypoxic ischemic insult. Okay. These are a few other patterns of neonatal HIE changes. So this is less profound hypoxia in a term neonate, where we can see this, the white matter gray matter distinction is still maintained, but it is lost at some places, mainly at the watershed region. Also here we can see bilateral parasagittal location of less profound partial hypoxia. Here we can see this white matter gray matter distinction is much more pronounced here, that is normal, but posteriorly in the parasagittal perirolandic location, that distinction is lost. The white matter and gray matter distinction is completely lost. So there is edema preferentially in the parasagittal perirolandic location. If we see the sequelae of hypoxic ischemic insult, so there will be either cystic encephalomalacia, that is the parenchyma will be replaced by cystic changes, or in cases of term babies, when they're replaced by gliosis, they won't be seen as cystic changes, rather there will be generalized atrophy, and the sulci and gygi, they will be appearing short and stunted. Now, in this baby, here we can see that there is diffuse atrophy of the brain parenchyma, supratentorial brain parenchyma, whereas cerebellum is relatively preserved. And whenever there is rapid brain atrophy, there can be rupture of the bridging veins, and there can be subdural hemorrhage. Here we can see bilateral subdural hemorrhage, and in chronic subdural hemorrhages, the leaves may calcify. That we see here, the subdural hemorrhage, they are calcifying. So in this CT, what we see is the cystic changes. This is how a cystic encephalomalacia looks like. Cyst formation within the cerebral parenchyma. However, a few entities may mimic cystic encephalomalacia, like sulfite oxidase mutation, or molybdenum cofactor deficiency. In these entities, the appearance will be similar like that of an HIE sequelae and cystic encephalomalacia. However, the definite history of hypoxia won't be elicitable, and if there is a family history of sibling death, then we need to be more cautious about raising this suspicion. Now, although this is not a neonatal CT, but I couldn't resist showing this good depiction of how an infarct looks like. So this is a territorial infarct. Here we can see bilateral middle cerebral artery territory. In this area, we can see that the white matter and gray matter distinction is completely lost. So there is loss of white matter gray matter distinction, and the sulci are effaced. So this is how a normal sulci looks like. So we can see the CSF space insinuating. Whereas here, due to the edema of the brain, the sulcal spaces, they are effaced. They are no longer seen. So this is typical of bilateral MCA territory infarct. As I showed earlier also, so this is a non-contrast scan, and the vascular structure should not be hyperdense. Now, on a non-contrast CT, if we see at this posterior aspect in the location of the superior sagittal sinus, this hyperdensity, if we see like this, then we have to think about venous sinus thrombosis, cerebral venous sinus thrombosis. Also, we can see that anteriorly in the frontal lobe, this space, this extraaxial space or the subdural space, subdural fluid is prominent, which is normal because the brain is bound to grow during infancy. So if we see this kind of pattern beyond infancy, then we can consider abnormality. But in an infant, this frontal and temporal predominant prominence of subarachnoid spaces can be normal. That is called benign enlargement of subarachnoid spaces. This is how, this is a neonate with what we see on a non-contrast scan is very hyperdense lesions within the parenchyma. Along with the adjacent white matter is appearing very, very hypodense. So this is how a bleed looks like with surrounding edema. This is intraparenchymal bleed. Also, adjacent to it, we can see some linear thing, hyperdense thing, which is going along the sulci. So this is subarachnoid hemorrhage. So here we can see intraparenchymal hemorrhage plus subarachnoid hemorrhage. Once out of this acute conditions, I will show a few congenital abnormalities. How do they look like? So in the earlier scans, we have seen that there are sulcation and gyration patterns which are well visualized. Now, if we look at this brain, that it is appearing very smooth. So this is a smooth brain which is giving right to this figure of 8 appearance. This is, listen carefully. In this, what we see is that there is a CSF filled space which is communicating with the ventricle, the frontal horn of the lateral ventricle. So we are dealing with a scission carefully. In this head CT, we see that there is a dark structure. Now, this black thing in a CT, it depends on the density that we could measure, but it can either be CSF or it can be fat or it can be air. So it all depends on the measurement of the Hounsfield unit on the console. This is a corpus callosal lipoma, a congenital abnormality. Now, in this infant here, we can see that there is periventricular foci of fine calcification, also basal ganglia calcification, and child had microcephaly. So we have to raise the possibility of a torch congenital CMV infection. Now, a child with increased head size and this typical appearance of batwing pattern of the Sylvian fissure is seen in cases of glutaric aciduria type 1. How do infections look like? Here is what we typically call a ring-enhancing lesion or inflammatory granuloma. So this is a disseminated tuberculosis in which we could see that these are the ring-enhancing tuberculomas with variable amount of edema adjacent to them. It is not associated with any, it is associated with some meningeal enhancement as we see over here. So this is how infection looks like. Very unusual indication in neonatal age group. Sometimes congenital tumors or tumors may present, although I agree that they are very rare. This is one such case where a newborn presented with a mass in the left CP angle with coarse calcification. This was a teratoma and it presented in the neonatal period with a mass which is having a very coarse area of calcification. So in short, these are rare situations, but we need to be aware of the normal appearances of the neonatal brain so as to differentiate it from abnormality, because detection of abnormality in an unmyelinated brain on a CT scan is really tough. I thank you all for your kind attention.
Thank you so much, Dr. Jana. It was a wonderful presentation. Really, a lot of learning. Dr. Mangalbharti, you had any comments to make? Probably we'll have the next talk, and then we can once for all have all the questions in the end. Can I have Professor Atin, please? Can you present your presentation? Thank you.
Sure, sir.
As Dr. Atin joins, if I can ask Dr. Manisha that there is a lot of concern about doing CT scan and potential risk of, say, malignancy later on among small kids. So how justified is that concern, and any Indian data to suggest that that is true?
Right, sir. So actually, this radiation risk that all what we have data now is all based on the nuclear explosions, and none of them are based on a routine use in clinical use of radiation. So the amount is, as you can really understand, that the amount is hugely different. So, and radiation effects, they're not cumulative. Like at some point of time, if we do one head CT because of a dire indication, which we cannot circumvent, but then that effect of that radiation is not going to stay there for say 6 months. So 6 months down the line, even if we need another CT, we may have to do it. So it's always risk versus benefit ratio. But yes, we don't have any data on neonatal head CT on a diagnostic scenario.
Thank you so much. Dr. Atin, please, can you start your presentation?
Right, sir. My slides are visible, I hope.
Yes, that's right. It's available.
Perfect, sir. So, after this wonderful presentation by Dr. Manisha, my job has been made easier because significant anatomy as well as pathologies she's covered. So she's covered predominantly CT scan. I'll be taking you through the basics of MR and the imaging pathologies which are commonly seen in the neonatology age group by on MR, and when to do MR, how to use it, how to read it, that I'll try and address in this next 30 minutes which have been given to me. Right. So first of all, we'll start with the basics of MRI brain. Like CT, you've got to know what are the advantages of MR. I'm sure many of you know, but there's still no harm in revising them. First and foremost is there is no ionizing radiation involved, right? So the question of radiation induced changes and that fear is not there. So we can do MR as many times as we can without even thinking about it. It's got a superior contrast resolution compared to the CT, does not cause interference with bone. So areas which are adjacent to the bone, sometimes we have issues with CT interpreting them, but on MR there are no such issues. So specifically for brainstem and for posterior fossa, MR definitely is the modality of choice. And lastly, many pathologies on MR can be seen even without contrast. Sometimes, especially the infections require contrast on CT. MR also, if it is we are suspecting infection, will like to give contrast, but certain pathologies can be seen only on MR without contrast, whereas for CT you would require to give contrast to visualize them better. That's because of better contrast resolution of MR. Having said that, it's all not glory all around because MR has limited availability, it's way more expensive. Even besides that, the major disadvantage for a MRI to be done in a neonate is a longer examination time. As Dr. Manisha clearly told about the advantages of CT in terms of the latest scanners, they can actually do CT scan of the head in as less than as 3-4 seconds. In fact, we can do a complete CT scan of the head in 3-4 seconds for a child. Whereas for a MR, you would at least require a 10 to 15 minutes, maybe sometimes 20 minutes. But even if we want to go fast, we'll require at least 10 to 15 minutes of MR. The child has to be within the gantry. That would, when we're talking about neonate, so the issues of sedation, issues of immobility, general anesthesia, they all pitch in. Although at our center, we've tried doing MRs even without sedation, especially neonates, getting them maybe sleep deprived earlier, or then giving them a feed, and then when the neonate sleeps, we can put them in the MR. But then again, when the child goes in the gantry, there is always issues of monitoring of the vitals of the child in the gantry. So that those all issues do come into the picture, and MR is contraindicated for cochlear implants, for metallic things, or for pacemakers which have been placed in the children. So once we know this, I'll not go into the physics of MR. It's slightly more complex than the CT, but the CT was based on the radiation, X-ray tubes giving radiation, whereas I can tell you in one line that MR is based on the multiple basically spinning protons in our body, which is present in all cells, all tissues of our body. When we align them in a very strong magnetic force, they actually align according to their magnetic dipoles. And once we give additional radio frequency pulses, they malalign. And when we remove the pulses, they come back to their energy state. So once they release the energy, there are electronic algorithms to check those energy states and convert them into gray and white images, which we can see and interpret. MR is not simple compared to CT, because in CT we have just one type of image which comes. That white matter is white, dark gray matter is bright, ventricles are showing fluid, fluid comes dark. That's all because of radiation or X-ray absorption properties of all the tissues. In MR, we can play around with the protons, the signal coming from that, based on the types of pulse which we give and the frequency of pulse which we give, to generate different signals from the same tissues, right? I'm sorry, but Dr. Manisha did tell about that we can play with the contrast levels on CT scan console to move the window to a bone window to a soft tissue window, but that's it. That's one image which is present. You just cannot take away the characteristics of a tissue based on the windowing which you do. But on MR, depending upon the type of sequences which you're using, you can get a white or a bright signal from the same tissue, or you can get a dark signal from the same tissue. Similarly, so you can get dark signal from the fluid, from soft tissue, from bone, from fat, or you can get a bright signal from either of these structures based on what sequences you do. So the basic sequences which we use in any MR are the T1 weighted sequences or the T2 weighted sequences. Most of the sequences are either T1 weighted or T2 weighted sequences. Let's see how do you first identify a T1 weighted sequence. The main principle for identifying a T1 weighted sequence is it looks to a certain extent like the CT scan image in terms, because on T1 weighted sequence, the fluid appears dark. Please remember this, the fluid appears dark on a T1 weighted sequence. By fluid, I'm just saying fluid. Fluid means any fluid. If in the brain we are looking at, we know there are fluid in the CSF, in the form of CSF, in the ventricles or the cisterns. So this is the CSF in the ventricles. We know by anatomy that this is the ventricle, this is the third ventricle. These are the cisternal spaces. So you see CSF here. And if the CSF is appearing dark, it's a T1 weighted image. Same here, CSF in the sylvian cistern, sylvian fissure, it is appearing dark, it is a T1 weighted image. If it was abdomen, I would have looked at the gallbladder to look at bile. If it was spine, I would have looked at the CSF in the spine. If it was the pelvis, I would have looked at the urine in the urinary bladder. If it was abdomen, I would have looked at fluid in the intestine, in the stomach. Any fluid, be it any form, would appear dark on a T1 weighted image in any part of the body, right? So when you're looking at brain, first look at the CSF space. If it is appearing dark, it's most likely a T1 weighted image, right? Then you also look at what the gray and white matter looks like. These are both T1 weighted images. The complexity here arises because of looking at white matter. The white matter we know becomes myelinated with increasing age. The initial unmyelinated white matter has a lot of fluid, water content within it, whereas once it starts getting myelinated, the water content of the white matter decreases and the lipid content increases. Water, I've told you, fluid appears dark. So on unmyelinated white matter, on a T1 weighted image, since it contains a lot of fluid or a lot of water component, will appear dark. So by anatomy, you know, Dr. Manisha has already told, the periphery gray matter appears like this on a convoluted pattern, and the underlying white matter on a T1 weighted image, if it is an unmyelinated white matter, because of the water content, the white matter appears dark. See, it is not as dark as a pure fluid. Pure fluid is absolutely dark, which is in the ventricles, but the white matter is also appearing dark an unmyelinated white matter. That's how you recognize a T1 weighted image in a neonate, which is an unmyelinated white matter. In contrast, this is a T1 weighted image in a child who has a myelinated white matter. So the myelination increases with age, but beyond 2 years of age, all matter gets myelinated. When the white matter gets myelinated, it becomes bright on T1 weighted image. I know it gets confusing, but do try and remember. So on a myelinated white matter is white, on a T1 weighted image, it still is a T1 weighted image. But when you're talking about neonates, and if you are going to see them, this is how the T1 weighted image would look like. This was a axial section. So one advantage of MRI is we can acquire in any plane. We can take axial sections, we can take cornal sections, we can take sagittal sections, we can take oblique sections. Whereas in CT, the acquisition is always axial, and you can do a reconstruction of those volumetric data in multiple planes. But in MR, you can actually directly acquire in any plane. So this is a T1 weighted sequence of a myelinated white matter in a sagittal plane. You can see the brainstem, the cerebellum, the parietal lobe, the frontal lobe, the occipital lobe in a sagittal manner. Okay. So on a T1 weighted image, I've told you it resembles CT brain in a manner that the ventricle or the fluid is appearing dark as it was appearing dark on a CT scan. The CSF is appearing black. Also important to note is basically the T1 weighted image is best for usually for anatomy, whereas T2 weighted image is better for looking at the multiple pathologies. Not to say that the pathologies we cannot identify the pathology on T1 weighted image, we can, but it is always better identified on a T2 weighted image. Also, T1 weighted images are required whenever we are giving contrast. In MR, when you are giving contrast, which is the dye which we give, in CT we give iodinated contrast, in MR we give contrast which contains gadolinium. The contrast material or the dye which we give appears bright on a T1 weighted image. So if you are giving contrast, you would want to do a post-contrast T1 weighted image to look at any enhancement which may be seen for any indication. Like Dr. Manisha told, the indication remains the same. If you're thinking in terms of any infection, if you're thinking in terms of any tumor, or thinking in terms of even inflammation, then you want to give contrast. And after contrast, the areas will appear bright on a T1 weighted image. Okay. Let's look at a T2 weighted image. The most important second component is a T2 weighted image. These are different ways of acquiring. So we acquire a T1 weighted image followed by a T2 weighted image. And the T2 weighted image, the CSF or any fluid will appear bright. So once you're looking at the brain, we're looking at the ventricles, we're looking at the sulcal spaces. If the CSF is appearing bright, we know we are dealing with a T2 weighted image. Again, the white matter signal depends upon a myelinated or unmyelinated. Since the unmyelinated white matter contains a lot of component of water, I've told you water is fluid, it will appear bright on a T2 weighted image in an unmyelinated. But once it becomes myelinated, the white matter starts getting dark. So if you see this is an unmyelinated white matter in a neonate, let's say a 2 days old neonate, but this is a 2-year-old or a 2-year-old plus child who has a myelinated white matter. So if you're getting confused, just look at the CSF. If the CSF is bright, it is a T2 weighted image. And in a neonate, 1 month, 2 month, 3 month, 4 month, 5 month, whatever you're looking at, the white matter will appear bright on a T2 weighted image. So, and I've told you already, most of the pathologies are better visualized on a T2 weighted image. There are some exceptions to this rule. I'll show you as you go along in examples, but for practical purposes, T2 we use for looking at and characterizing the various pathologies. Okay. Then there is another sequence which you know, which is known as a flare sequence, which is a fluid attenuated inversion recovery sequence. Let's not go into the details, but what I can tell you is flare is a type of a T2 weighted sequence in which you are suppressing the signal of the fluid. So becomes complex. If you look at the fluid, you would want to know that it is, if it was bright, it was T2, but on a flare, the fluid in the ventricles gets suppressed and it becomes dark, whereas the rest of the brain parenchyma appears like a T2 weighted image, not like a T1 weighted image. Advantages, I'll show you as you go along. Actually, for all practical purposes, in the neonatal age group, when the white matter is unmyelinated, flare is not of much use and not of much significance. I do not particularly use it in my standard protocol for imaging unmyelinated white matter. There are only specific scenarios in which we use a flare image when we want to look at any cystic change. Then flare image is required, it is useful, and I will show you how to look at a cystic change on a flare image. Then the next is a diffusion weighted image. Basically, we've all heard about it, we all know. It is based on the free Brownian motion of all particles. At random Brownian motion occurs in a normal cellular cell. It leads to no restriction of diffusion in any particular cell. If there is any cytotoxic edema which occurs in any particular cell, it leads to a very constrained environment for a free Brownian motion of the intracellular atoms. It leads to a restricted diffusion. This same property we can utilize by doing some form of MR imaging, which we call as a diffusion weighted imaging, in which we can try and see if there is any restriction of diffusion in any particular cell, which occurs when there is any cytotoxic edema. So how do you identify diffusion weighted image? It looks like a very dirty type of image, like you can see here, when you cannot even identify the skull wall, the bones, the subcutaneous tissue, and when the brain parenchyma looks a very poor resolution type of an image, but the CSF is dark and you acquire this. This is a diffusion weighted image. You always see a diffusion weighted image in conjunction with a ADC map. You would have heard this term, apparent diffusion coefficient map. This is nothing but a mathematical representation of a diffusion weighted image, and it is almost an inverse of a diffusion weighted image. So in this, the CSF appears dark. On the ADC map, the CSF appears bright. This has got a T2 component, and we see both of them together to decide if there is diffusion restriction or not. Diffusion restriction is not specific for ischemia or infarct. It was first advertised as detecting infarcts, ischemia, because of the cytotoxic edema. Yes, it does play a role, but anything which is acute, which leads to a cytotoxic edema, acute inflammation, acute, let's say, abscess, tumors with high cellularity, they can all lead to a restricted diffusion. So diffusion weighted imaging we'll use when we want to look for ischemia or acute inflammation, or we want to characterize something with a very high cellularity. Okay, I'll show you example here. This is a T2 weighted image. Why do I say this is a T2 weighted image? The CSF here appears bright and this is the unmyelinated white matter. But I do see some abnormal asymmetry here in which there is an abnormal hyperintensity. Hyperintensity. Look at the word. We use the word intensity to describe any signal change on MR images. Like we use the word density on CT, and we use the word echogenicity or on ultrasound, we use the word intensity on MR. So when we call it hyper intensity, that means it is bright. When we call it hypo intense, it is dark. So this area is appearing bright on a T2 weighted image in the periventricular location. So I know that there is some abnormality here because God has given us two sides of brain. There is asymmetry, so I know this is not normal, right? This is something, if in the clinical setting, I know that child is presented with a acute left hemiparesis, then maybe I'm thinking in terms of acute infarct in the right periventricular region. Then if I do a diffusion weighted image, so remember this is a diffusion weighted image, a dirty looking image without, when you cannot see the bone or the scalp. See, on a T2 weighted image, you can see the bone, you can see the scalp, but on this you cannot see it. This same area appears bright, that it is appearing hyper intense on a diffusion weighted image, and on the ADC map, since it is reverse, it is appearing dark. A combination of this tells me that there is a significant diffusion restriction here, and the utility of diffusion weighted images, it tells me it is acute, it is leading on to a cytotoxic edema. So I know this is the infarct because the patient has a hemiparesis, but I can tell that this is an acute infarct because there is diffusion restriction. That is the use of diffusion weighted image in this particular setting. Also, let's look at this particular section. I'm sorry, but this does not contain the ventricle, but still you can identify it as a T1 weighted image. This is not in a small child, in a neonate. It is in a myelinated white matter. The white matter is bright, but the CSF is dark. In the sulcal spaces, the CSF is dark. This is a T1 weighted image. What I want to show you here is there is something which is hyper intense, which is bright on a T1 weighted image. There are very few things which are bright on a T1 weighted image, extremely bright like this. If you see something extremely bright like this on a T1 weighted image, do think in terms of a hemorrhage. Hemorrhage because of the methemoglobin appears bright on a T1 weighted image. So if you see something bright on a T1 weighted image, do think in terms of a hemorrhage. So there is a very bright area on T1 weighted image, hyperintense area, surrounded by a iso-intense area on this side. On a T2 weighted image, this is a T2 because the sulcal spaces which contain CSF are appearing bright. This area shows heterogeneous signal, some dark areas, some bright areas, another area which is appearing dark here on a T2 weighted image. So on a T2 weighted image, most of the pathologies appear bright, that is hyperintense, like this. But again, hemorrhage, as it was appearing bright on T1, the hemorrhage usually appears dark on T2 weighted images. Again, there is complexity in this. It can appear bright, it can appear dark, but let's for all practical purposes remember that hemorrhage can appear dark on T2 weighted image. So if you have a bright signal on T1, dark signal on T2 weighted image, do think in terms of a hemorrhage, right? You want to identify bleed. For bleed, CT scan is the best modality. We all know CT scan picks up bleed very quickly and very early. If you're suspecting a bleed, we normally get a CT scan done rather than an MRI. But I want to tell you that MR can also pick up bleed by a combination of T1 and T2 weighted images. If you do a special sequence, which is known as a susceptibility weighted sequence, it is a type of a gradient sequence. These are the words which you will commonly hear radiologists talking about. Then you can clearly see the bleed very well. These are sequences which are geared to identify bleeds very well, and you can see very dark areas. So it was appearing dark on T2, but it is appearing significantly dark on these sequences, and it can identify bleed. So you can identify bleed. So if you're suspecting bleed, we ask for a susceptibility weighted sequence or a gradient sequence, and it can clearly detect the bleed. And I'll show you multiple examples as I go along. So another example, in this case, the T2 weighted image, ventricles are showing bright signal, shows some dark areas here. Query bleed, was it bleed? We did a susceptibility weighted imaging. We know now that it is a bleed because it is appearing significantly dark. We term this thing as a blooming. You will use this, you will read this word, blooming on susceptibility weighted imaging confirms that it is most likely a bleed. Calcification can also show blooming, but a bleed can also show blooming. And for all practical purposes, let's call it as a bleed. Another example on a T2 weighted image, on a susceptibility weighted image. Then on MR, we can also do angiography. We can do a arteriography. We can ask for a venography depending upon whether we are suspecting an arterial occlusion or arterial abnormality or a venous abnormality. There are different techniques in which we can acquire. We'll not go into the detail, but this is how a venography will look like. This is the anterior posterior view where you can see the superior sagittal sinus, the right and the left transverse sinuses, the sigmoid sinuses, the internal jugular vein. On a sagittal lateral view, this is the superior sagittal sinus, this is the straight sinus, this is the vein of Galen, this is the internal cerebral veins, these are the transverse sinuses, these are the sigmoid sinuses, and this is the internal jugular vein. You can see very well. Similarly, you can do an arteriogram in which you can see the internal carotid arteries dividing into the anterior cerebral and the middle cerebral arteries. These are the A2 segments, these are the M2 segments. Then this is the vertebral artery, two vertebral arteries. This is the pica. This is joining to form the basilar artery. You can see the superior cerebellar arteries and you can see the posterior cerebral arteries. If you acquire this type of image, this is MR angiography. MR arteriography and MR venography can be done without contrast. That is the advantage. You do not require to give contrast. You can get all these images. These are all images which are been done without giving contrast, right? On a CT scan, if you want to do a CT arteriogram or a CT venogram, you have to give contrast. There's no other way. That's the advantage. Okay. When do you give contrast and what's the advantage of giving contrast? On a plain T1 scan, the pathologies are not too evident, I've told you, but the pathologies which shine with contrast, we all know, infections, tumors, inflammations. Once you give contrast, like a pathology was here, but it was difficult to identify it. Once we give contrast and then we take a T1 weighted sequence, the pathology shines with contrast, becomes bright. This is the same pathology here, becomes so much better evident here. That's the advantage of giving contrast. So you have to ask for contrast whenever you're thinking in terms of an infection or a tumor or a inflammation, right? Okay. Now let's look at normal examples of a MR of a neonate. So I've told you on a neonate MR, This is the T1 weighted images. These are the T2 weighted images. How? The CSF is dark here, CSF is dark here, circles, CSF is dark, the CSF is bright, CSF bright, CSF is bright in the sulcal space. The unmyelinated white matter is dark here, the unmyelinated white matter is bright here, right? These are the T2 weighted images. This was at the level of the basal ganglia. This is at the level of superior basal ganglia. This is at the level of centrum semiuval as we are going up. This is a 1-day-old term neonate. However, with increasing myelination, as you go from birth to few months to increasing months, the white matter becomes brighter. See, it was dark here, it becomes brighter, and ultimately it becomes pretty bright on a T1 weighted image. And on a T2 weighted image, the bright white matter starts to get dark and becomes darker on a T2 weighted image as a myelinated white matter. This is the progression of myelination. I know you are not too much concerned about a later age, but you should, if you get to follow up your patients who come with the MRI, which has been done later, you should know that you would be expecting a dark white matter on a T2 weighted image. So I'm showing you this is how a normal myelinated white matter looks like on a T1 weighted image, on a T2 weighted image. With this background, let's look at some pathologies and principles. I've told you generally pathologies are dark on T1 weighted image and bright on T2 weighted image. There are some exceptions to this rule. For all practical purposes, what I'll be showing you today is bleeds, multiple bleeds. That is the exception to the rule. Bleed is often bright on T1 and dark on T2 weighted image. And that's what we will try to look at compared to the normal pathologies when we are trying to interpret bleeds. And let's look at some cases. So I'll again start with the most common thing which you see in your day-to-day practice, which is the HI or hypoxic ischemic injury actually. We all know it's basically divided into premature and term neonate. Dr. Manisha covered it pretty well. And even in premature, the division is more. If it is less than 34 weeks, there are chances of hemorrhage because of the germinal matrix present. If the the insult occurs more than 34 weeks, then there is no chances of hemorrhage, but it's just periventricular leukomalacia pattern which occurs. And this is in the periventricular because the watershed zone is in the periventricular. Whereas in the term neonate, the watershed zone shifts to the subcortical location. So any ischemia we'll see at the periphery. Let's see the examples. So this is the upper section is what? It is a T1 weighted sequences. The ventricles are dark. The lower sections are T2 weighted sequences. The ventricles are bright. The CSF spaces are all bright. These are the CSF spaces, dark, bright. But what we see abnormal here is in the ventricles on the T1 weighted image, we do see some bright areas. CSF is dark. We were supposed to see dark, but on these ventricles, we're seeing bright signal in the ventricles on the T1 weighted image and dark signal in the ventricles on the T2 weighted image. I've told you for all practical purposes, we'll call this as bleed. Something which is bright on T1, dark on T2, we're thinking in terms of a bleed. So this means that there is bleed in the ventricles in this child, in a preterm child, intraventricular hemorrhage. And when we are doing a susceptibility weighted sequence, as I've told you, that is the best sequence to detect hemorrhage. We can clearly see dark areas within the ventricles and also outlining the choroid plexus and the germinal matrix. Dark areas in the chordothalamic region in the germinal matrix. This is a classical case of a intraventricular bleed, choroid plexus bleed, germinal matrix bleeds with intraventricular bleed. So a pattern of hypoxic injury in a preterm neonate, which leads on to a bleed pattern. Let's see another example. The advantage of MRI is over CT. CT will detect bleed only in the acute to a subacute stage when it appears bright. Once it goes to a chronic stage, the bleed no more appears bright on CT, no more appears hyperdense on CT, and you will not be able to identify bleed on a CT scan if it is a chronic or a remote bleed. On MR, the advantage is even if it is a remote bleed, because once there is blood, it leads on to ultimately hemosiderin formation. Hemosiderin can be picked up on MR at any point of time because of the macrophages. They engulf the hemosiderin, they remain there with the hemosiderin in situ, and MR can detect hemosiderin anytime. If it was a bleed in the neonatal period and MR is done at 30, 40 years of age, we can still pick up bleed which was present at that point of time. So even a remote bleed can be picked up. That is the advantage of MR. So in this neonate, it is a 7-day-old child. MR was done on the T1 and T2. On the T2, the we were having a doubt of this being slight hypointense. Again, some dark area appearing here in the ventricle, but we're not too sure whether this is a bleed or not. But once we did a susceptibility weighted sequence, which I told you, it was something which was blooming up. We were confirmed that there was a bleed in the ventricle in this patient, which was maybe a chronic bleed, which had happened maybe antenatally, we are not sure, but this was a bleed which could be picked up. Another patient, T1 weighted sequence, dark ventricles, T2 weighted sequence, bright ventricles. On a T2 weighted sequence, you can see a dark area at the junction of caudate and thalamus, caudothalamic groove. So you know when we're looking at dark T2, is this a bleed in a preterm child? I'm thinking in terms of a bleed. Once I do a susceptibility weighted sequence, I can clearly see that the bleed blooms up. So I know there was a bleed in this child, and this is how we can pick up. So if you're suspecting a HI, ultrasound is the first modality which you do, which radiologists do. We can pick up bleeds, but again, ultrasound can pick up bleeds in the early form. Once the bleed subsides, then you cannot pick up bleed in the ultrasound. But if you've not done ultrasound at that point of time, or if you're not sure, but if the MRI has been done, let's say 7 days, 10 days, 20 days, 1 month down the line, you can still pick up that there was a bleed in this child in the caudothalamic groove, maybe antenatally, maybe at the time of birth. But this will tell you that the bleed occurred when the child was less than 34 weeks of gestational age. So accordingly, you can know whether it was antenatal or even if it was a preterm delivery, maybe at the time of birth only, but the child had to be less than 34 weeks to have this kind of a bleed pattern. Another example, I'll show you multiple examples of the same pathology, but this is just to reinforce that we can pick up subtle bleeds in the germinal matrix, which can very well be seen on a gradient sequence as dark things like this, and these can be picked up. Again, this is a case of T1 weighted sequence, but a gradient sequence can clearly see dark outline of the ventricle systems. Even the choroid plexus is showing, the germinal matrix is showing. We all know that there was a germinal matrix bleed and a chronic intraventricular bleed which was present in this particular case also. Okay. Sometimes then there can be periventricular leukomalacia. Not all insults are hemorrhagic. Then there can be ischemic insults also. Early periventricular leukomalacia can appear slightly bright on T1. It is difficult to appreciate on T2 weighted images, but this child had a periventricular leukomalacia. And once you follow up, we all know there is a formation, there is a stages of periventricular leukomalacia, then it leads to a cyst formation. And ultimately this cyst merge, as you can see on the sagittal sequence or on the axial sequence, this cyst merge with the ventricle wall. There is a complete loss of the ventricular volume. As Dr. Manisha also told, there is no glial response in the preterm neonates. So it is all liquefaction which occurs, and it ultimately leads to a significant volume loss of the white matter and leads on to a ventriculomegaly, which you can ultimately see. And this is not a neonate, but this was done at 7 months of age, when you can see clearly telltale signs of a periventricular leukomalacia. There is severe paucity of white matter. There is ventricular enlargement. Ventricular margins are irregular, and the corpus callosum is significantly thinned out. All this is a triad of PVL as a sequelae of PVL, which had occurred in this child. And by seeing this, I know that this child had an insult in the preterm period itself, which had led on to a periventricular type of a insult in this child. Contrast this to a different type when the insult is profound and brief. In this case, there will be a central pattern of insult. The periventricular leukomalacia is a prolonged, not so profound type of insult. If it is a profound and a brief insult, the most metabolically active regions of the brain get abnormality because they require the most amount of oxygen, and there is no time for autoregulation to occur. So the basal ganglia and the thalami get abnormal. So if you see, these are the T1 weighted images. The ventricles are dark. This is the T2 weighted image. The ventricles are bright. On the T1 weighted image, there is slight hyperintensity of the posterior putamen and the thalami. This is abnormal. However, once you do a diffusion weighted image, you can clearly see that there is a diffusion restriction in the anterolateral thalamus and partly in the posterior putamen. This is the ADC map I've told you. Once you see this, you are sure that there is some abnormality in this region which is involving the anterolateral thalamus. So this is a profound hypoxic injury in a child This pattern can be seen in a preterm neonate as well as a term neonate. Depending upon whether it is preterm or term, there will be more involvement of either thalami or of the basal ganglia, but both of these can be involved in a term or a preterm neonate in a severe profound hypoxic insult. Once you follow up these patients, the sequelae which you see later on is a significant atrophy of the thalami with some hyperintense signal change and posterior putamen. This is what we often see if the imaging was not done in the acute period. This is something which I've shown you at the acute period, but this is something which you just see on follow-up. If you follow up these patients 6 months, 8 months, 1 year, 2 years, 3 years, you can see this. Just by seeing the sequelae, you can tell that at the perinatal time, there was a significant insult, hypoxic insult, which had occurred, central pattern of insult. At the acute time, this is another example. You can see marked signal changes on the T2 weighted image involving the basal ganglia and the thalami on the T1 and the T2 weighted images. This is again profound insult. Sometimes you can also look, this is slightly difficult for you, but you should know that there is a sign known as an absent plaque sign. We all know that the posterior limb of internal capsule starts to get myelinating at 37 weeks of gestational age. So if you do a MRI at 37 weeks of gestational age, you can see some myelination occurring in the posterior limb of internal capsule. However, if you do a MRI of a child, let's say 38 weeks, 39 weeks, 40 weeks, 41 weeks, or a postnatal MRI, and you do not see myelination in the posterior limb of internal capsule, this is one sign which tells you that there is some insult which has occurred, which has led on to either delayed myelination of the internal capsule or maybe a dysmyelination of the internal capsule, the posterior limb. This is one sign we look at when we are looking at the term MRI. Please remember, this sign can be used only when the child is more than 37 weeks of gestational age, because that is the time when the posterior limb of internal capsule starts to get myelinated. Okay, let's look at another pattern. This pattern is, this is a diffusion weighted image. Look, see a dirty looking image without a skull vault which is seen. Dark CSF, diffusion weighted image. What you can see here is there are areas which are appearing bright in the bilateral frontal lobe watershed territory, bilateral parietal occipital lobe, gray matter. Large areas, gray matter involvement. This is also a hypoxic injury which is involving predominantly a gray matter. But what type of hypoxic injury is this? If it was a profound acute insult, it would have led on to an involvement of the basal ganglia. But in this case, it was a slightly prolonged insult, slightly profound, but not too profound, but it gave time for auto-regulation so as the body to save the basal ganglia, but the cortex, especially the watershed areas, could not be saved, and the cortex got involved. And this was a moderate and a prolonged type of insult where you can have a diffuse cortical pattern type of insult. Again, this can be very well picked up on MRI, best picked up on diffusion weighted sequences. Again, this was the same example Dr. Manisha also showed. One CT in which there is a diffuse abnormality of the gray white matter. Thalami is spared, but the basal ganglia are involved, the gray white matter is involved. The same child, when you follow it up, shows diffuse cystic encephalomyelitic changes in all those areas. This was an acute scan. This is a subacute to a chronic follow-up of the same child. Cystic encephalomyelitic changes are seen, and this is a cerebral devastation pattern. Then there can be certain other patterns of HI also. You can see a focal cystic change, like you see in a periventricular cyst which get formed. The T1 weighted sequence, again dark CSF, T2 weighted sequences. What you can see is a dark area, hypointense area, rounded in the periventricular location adjacent to the caudate lobe on T1 and appearing bright on T2. Again, if it is a cyst, it would contain fluid. Fluid is something which is dark on T1 and bright on T2. So you can see and diagnose small cystic lesions, which you can see very well on ultrasound also, but you can diagnose them on MRI also if you have done the MRI, and you can clearly see them on FLAIR also. I told you there is some advantage of FLAIR only if when you are looking at a cystic lesions, you can use FLAIR. They can identify them very clearly, better than T1, better than T2. You can identify them on FLAIR sequences also, small cysts also. Another example, you can see some septations within the ventricle. So these are germinal matrix, or these are choroid plexus cysts which may have formed secondary to hemorrhage in the choroid plexus. Again, can be seen on MR also, and you can see them on FLAIR also. Another example, in this you can see ventriculomegaly. You can see there is asymmetry in the size of the ventricles. These are the T1 weighted images. These are the T2 weighted images. The right ventricle is significantly enlarged. There is ventriculomegaly. But what is the cause for this ventriculomegaly? If you see carefully with the astute eyes, you can see there are some bright areas in the wall of the ventricle here, some dark areas on T2, bright areas on T1. Again, it means that there is probably some hemorrhage. What we would do if you are suspecting hemorrhage, you would do a susceptibility or a gradient weighted sequence, and you can clearly see dark areas in the germinal matrix along the ventricular margins. You can pick up this hemorrhage also here. So hemorrhagic insult. Let's look at this example. In this case, these are the T2 weighted sequences. These are the T1 weighted sequences. On T1 weighted sequence, some things which are appearing bright. On T2 weighted sequences, lesions which are appearing dark. There are bright lesions and dark lesions. Again, remember my dictum. Bright areas on T1, dark areas on T2, I am looking for hemorrhage. But now the different point here is this hemorrhage is not within the ventricles. So I'm not showing you a intraventricular hemorrhage, but I'm showing you hemorrhage within the brain parenchyma, a large area of hemorrhage within the brain parenchyma in this child. Right? What are the causes for intraparenchymal hemorrhage? Could be coagulopathy, vitamin K related disorders, coagulopathy of newborn. It could be a venous infarct, which can lead on to a hemorrhagic infarct. So you have to keep this in mind. Look at the coagulation profile. When you're thinking in terms of a venous infarct, always good to look at and suspect a venous sinus thrombosis. Better to look at sinuses and get a MR venogram. This is the superior sagittal sinus. Dr. Manisha told you this is how superior sagittal sinus appears on a cross section. You can see that there is some abnormal bright signal on T2 weighted images as well as on T1 weighted images in the superior sagittal sinus. This tells me that I am suspecting a superior sagittal sinus thrombosis in this child. This is also thrombosis of the transverse sinus. So I go ahead and do a MR venogram. Before that, I do a susceptibility weighted sequence. So I clearly see that the hemorrhage is blooming up, and this confirms the hemorrhage, although I was sure of the hemorrhage on the T1 and T2 also. And this is the sagittal, this is a T2 sagittal, this is a T2 corneal image. I'm sure you can identify corneal sections and sagittal sections. This has been done because this has been shown because this is showing abnormal signal in the superior sagittal sinus on corneal and as well as sagittal images. And we go ahead and do a venogram. We can see that the superior sagittal sinus is not visualized, only some part of it is visualized. The left transverse sinus, sigmoid sinus, internal cerebral veins, the right sigmoid sinus are all completely not visualized. They are thrombosed. And this child had a CSVT secondary to and a venous infarct, hemorrhagic venous infarct. Okay, this is another example. This a similar case has been shown by Dr. Manisha. If you see extensive cystic encephalomyelitic changes involving the subcortical white matter as well as abnormality of the gray matter, and if you know by your history that this presentation was not exactly at the time of birth, but maybe started 3-4 days down the line, and continuously the child gets worse over a period of time, you have to think in terms of a molybdenum cofactor deficiency or a sulfite oxidase deficiency. And this was a classical appearance on a child who had a sulfite oxidase dipstick X, which was positive in this case. Okay, let's look at some other pattern. In this, what is the pattern here is, these are the T2 weighted axial images in another child. Bright CSF, T2 weighted image. Unmyelinated white matter, I'm talking about a neonate. But what is abnormal is there are some bright T2 signal changes in the parieto-occipital white matter here, or a gray matter also. When I do diffusion, I see diffusion restriction in this particular area in the occipital lobe. Okay. Could be related to HIE. We all know that is also in the peritrigonal regions, but it is involving the gray matter also. HIE would typically involve predominantly the white matter. When a gray and a white matter, especially of the occipital lobe, is involved, especially if you tell me it was a preterm neonate, I want to suspect that it could be a hypoglycemic injury. Often there is a history of hypoglycemic episodes available with us. Once we are looking at a hypoglycemic insult and we want to do MRI, these are the areas we want to look at. Early stages, diffusion restriction, but if you're doing it 7, 8, 10 days down the line, there will be no diffusion restriction, but only T2 signal changes. And once you follow up this patient, a follow-up of this same child 2 years down the line shows significant encephalomyelitic changes in the areas which were earlier involved with the hypoglycemic insult. These are the classical findings of a hypoglycemic insult. Okay, Let's look at this particular MRI. This is exactly not a neonate, but it was 3-4 month old child, but I'm still showing you because of the T1 weighted image on a T2 weighted image. What you can see abnormalities on the T2 weighted image, there are abnormal signal changes in bilateral globus pallidi. These are appearing bright on T2 weighted images. This may be non-specific, but in a child with significant kernicterus with hyperbilirubinemia in the neonatal age group, MR can detect sequelae or telltale signs of kernicterus. So if we see this, this is usually not so well seen in the early neonatal age group, but once you follow it up, you can see abnormal signal changes which are persisting 3, 4, 6 months, 1 year down the line in the globus pallidi. We can be sure that this can be related, especially if there is a history of kernicterus, we can tell you that this is definitely related to a hyperbilirubinemia. And if there are any dystonias which are coming in this child, this can be correlated and do not further require any metabolic workup in this segment. But having said that, there are some metabolic diseases also, many inborn errors of metabolism which can also present in the neonatal age group. I'll not go into detail, but I'll just show you a couple of them which have a very classical presentation. This is one MR of a 19 days old child. In this case, the child had an acute encephalopathy, and the MR was done, which showed a classical presentation on the T2 weighted sequences. This is T2 because the CSF is bright. There was abnormal signal changes in the cerebellar white matter, dorsal brainstem, the corticospinal tracts in the pons, the dorsal midbrain, the globus pallidi, and the thalami, and extending into the internal capsule, going on to corna radiata. Bright signal changes in these particular areas in a child, in a neonate with encephalopathy. And if you do diffusion weighted sequences, they show bright areas on diffusion weighted imaging, significant diffusion restriction. In the right clinical setting, these images are diagnostic of a maple syrup urine disease. And you can actually get the assay level done to confirm the maple syrup urine disease. Okay, this was my last case. I think I've overshot my time by 10 minutes, but I had a lot to show. Still, I could have shown much more, but I am sure this is too much to absorb at this point of time. What I would suggest is go back tomorrow itself, look at some normal images of a neonate T1, T2, look at normal pathologies, maybe Google, maybe in your textbooks, and you'll absorb it better what I've shown you today. I will just end with the take-home message that have a systematic approach, look at T1, identify the sequences, look at T2, try to look for abnormal signals. God has given us two halves of the brain which are more or less absolutely symmetrical. Look at one pathology. If it is asymmetrical, there is a pathology usually present. Look at bright signals on T1 or dark signals on T2. They signify bleed. You can pick up bleed on MR. I've shown you multiple patterns of HI. I've shown you hypoglycemia, shown you some inborn errors of metabolism, kernicterus, and that's it. One point which I want to highlight here, which was asked by Dr. Ashish to tell also, when you're suspecting a HII, hypoxic ischemic injury, whether you should go ahead and do a CT, ultrasound, or MR. Ultrasound is the bedside modality. There's no harm in doing an ultrasound. You can pick up the periventricular flares, you can look at the cystic changes, periventricular leukomalacia, you can detect the hemorrhages, you can follow them up also. But sometimes the subtle changes ultrasound will not pick up and may not pick up in the very early stage also. Or if it is remote, if it was a hemorrhage which was remote, ultrasound will not pick up. Then you may require MR to be done. CT is not the modality of choice to look for hypoxic ischemic injury. It can pick up. It's not that it cannot pick up, but it can miss a lot also. If you do not have a MR, if you're not confident on ultrasound, you can get a CT scan done. If you pick up, well and fine. If you do not pick up, does not rule out. If you're thinking in terms of a hemorrhage, yes, you can get a CT scan done. It's as good as a MR, pretty good to detect hemorrhage if done in the acute or a subacute stage only. If it is remote or chronic, then CT scan will not even pick up hemorrhage. So you want to get a MR done. MR can pick up changes of hypoxic ischemic injury as early as few hours, couple of hours, theoretically. You can start seeing changes on the diffusion weighted image. They can start showing you some diffusion restriction. MR spectroscopy can show you some abnormal metabolites in as early as few hours. However, these are also subtle changes. At this point of time, the changes will not be seen on T1, T2, flare, any other sequence. The changes gradually start appearing on T1, T2 weighted sequences over a period of 24 to 48 hours. Even the diffusion weighted signal changes also increase to their maximum intensity over a period of 48 hours. So if you ask me what's the best time to do a MR, it's between 48 to 72 hours where the changes are best seen on T1, T2, diffusion. They are seeing the best on diffusion at this time of also. Although diffusion can pick up earlier, but the best diffusion changes are seen at 48 to 72 hours. Even the spectroscopy findings are best seen at this point of time. So 48 hours to 72 hours is the best time to do MR. But you would argue that I want to look at hypoxic injury at the initial time when I want to start with some measures. Why should I wait for 3 days to look at hypoxic injury? You all know that you do not stop your measures even if you're thinking in terms of a clinical scenario to stop your measures. You do your clinical measures, you do your hypothermia, whatever you want to do, and treat the child accordingly, suspecting hypoxic injury. But if you are not sure over a period of 24 to 48 hours if the injury has occurred, if you want to document it, if you want to prognosticate it, how much has happened, then get a MR done. 48 to 72 hours, the best time. But even if you want to know, even if you get a MR done later on also, it will tell you the chronic changes. It can prognosticate, but the acute changes cannot be picked up later on an MRI. The diffusion weighted changes are seen up to 7 days only, maximum 10 days. If you do MRI after 10 days of after insult, there will be no changes on diffusion. Then you cannot time it. You cannot tell when it happened. You can just tell there was some chronic changes which have happened. It could have happened 5 days earlier, 7 days earlier, 1 month earlier, 2 months earlier. I cannot time it at that point of time, whether it was intranatal, postnatal, whatever. But if I have done diffusion, I can tell you that this happened within the last 6 days, 7 days, if it is showing bright on diffusion. So, yeah, I'll end up with this. Thank you so much. If there are any questions, I'll be glad to take.
Thank you so much, Professor Atin. It was a wonderful presentation. You clarified so many things. In fact, what was very foremost on my mind was the detection of HI changes. And as you rightly said, diffusion weighted imaging can probably underestimate things if it is done too early. And you need to have that window period. Neither do you want to overestimate, because prognostication becomes very difficult, especially if you're doing therapeutic hypothermia and the child is still sick and encephalopathic. People want to know prognosis. Just a question about MR spectroscopy. You look at what metabolites would you say are the best for prognosticating these babies?
So, whenever there is cell death or there is ischemia which occurs, the NAA goes down and lactate increases. So, what is the best marker to look for any signs of ischemia is increased lactate. That's what we want to look at when we are looking at, or we want to use spectroscopy for detecting this. Having said that, this is a non-specific marker again, lactate. We all know lactate can increase in so many other pathologies. It's non-specific. But it's just that if you detect lactate in early spectroscopy scans, you can start to know that there is some abnormality, some insult which has occurred in the child. And maybe if that's what you're looking for, you can start your therapeutic measures then and there itself. However, having said that, practical scenarios, we do not use MR spectroscopy in this much early child to diagnose hypoxic ischemic insult. If you're doing a scan, which is indicated required, you can get a spectroscopy done. If you're having any doubt whether the initial the parameters on T1, T2 are matching or not, spectroscopy can at max be used as an adjunct. If it also showing increased lactate, you can maybe think, yeah, I'm looking in terms of ischemia. But we all know the metabolic disorders, especially mitochondrial disorders, can also have elevated lactate. So you'll have to take that into picture when you are using spectroscopy. Also, if you're specifically looking for other inborn measures of metabolism, then there's a much wider role of spectroscopy. You can look at amino acids, even in MSUD, you can look at branch chain amino acid peaks. You can look at deficiency of creatinine in creatinine deficiency disorders. You can look at hyperglycemia, where you can look at glycine peaks. So those are different uses of spectroscopy where you can use in a neonate also.
Thank you so much, Professor Atin. Professor Manisha, there's a question for you from one Dr. Kanya. Should we do a CT or an MRI if we suspect intracranial calcifications, like in torch infections?
So, Manisha, I think is not there, but I can take
Nothing,
this.
please.
It's fine. Generally speaking, CT scan is very good for calcification. It is the best modality for calcification. It was always better than MR for detecting calcification. But with better resolutions of MR and good quality sequences which are coming up, even MR can detect calcification reasonably well if you do special sequences. And in a trained eye, calcification can be detected very well on MR also. But having said that, if you are wanting to detect subtle calcifications, CT is any day better. Any day better. So
That's
even
our-
in my practice, even if I have a MR with me, I have gone wrong, even not picking up calcification on MR, absolutely gone wrong. But once we've done a CT scan, we've picked up calcifications. So if you have, I have to answer one, then CT scan is the modality of choice.
I think Professor Mangalabhati is back again. He had some network issues. Dr. Mangla, you have any comments
Yes.
to this, please? Yeah.
First of all, again, so it was wonderful listening to such a beautiful and simple but illustrious lecture. So you rightly pointed out and emphasized the ideal timing for doing an MRI in an hypoxic ischemic injury. But what I would like to ask from you, sir, the 48 to 72 hours, you also said that we can't withhold our interventions like cooling or whatever it is we have to go on. But what about the practical difficulties of actually moving a baby at 48 to 72 hours to get an MRI? Because we always find one of the most important reasons why people prefer a CT over MRI is the ease with which this investigation could be done. So is there any progress, or at least in the near future, things like a shorter version of an MRI or less sequences, neutral specific? Is any such thing possible, sir, which will make getting an MRI done easy in a sick neonate?
Right, sir. So that is the reason that in my collection, over a period of last 18 years since I'm doing pediatric neuroradiology, I have some collected images of my interest of some 200, 300 HIE, different types of patterns in my. But when I was told that I have to take for neonatologist, I had to search for a MRI of 1 month only. I could just find 10, 15 MRs out of those 200. It's that infrequent that those children are actually subjected to MR examination because of practical issues only. If it is required, what we've done at our institute is the neonatologists usually accompany. They, of course, when the child has to be stable, and we try and do a abbreviated protocol with smaller sequences, right? We can do a faster sequences. We know what we want to look at. If it's just to prognosticate, we can just do a diffusion and a T2, and we want and add it with a susceptibility weighted sequence to look for hemorrhage. These three things together we can do. Maybe we can finish the MR in 6-7 minutes only with a reasonable amount of resolution. Please remember, the faster we do the MR, the less resolution it gives. The longer time we give for MR sequences to acquire, the better is the resolution. So there is always a trade-off. But nowadays, portable MR machines have also come into the picture. They are available. They are FDA approved. They are available in US, worldwide also, especially the neonates. The MR can be taken to the bedside in the neonatology itself, and the MR brain can be done. Those quality images are not as good as the normal which we are used to see. Those are very low Tesla, 0.05 or even less than that actually Tesla images. Having said that, still they are giving reasonable enough images to detect subtle at least gross findings of HIE. We are also in the process of getting one through in fact, a grant. One of it has actually probably come in CMC Vellore also, and one is likely to come with us in the next few months itself, a portable MRI. That is the way forward for imaging neonates at the bedside itself, actually.
Sir, Atin, just to add to that question, suppose a child is on inotropes. Like right now, I have a child with 3 inotropes, just finished therapeutic hypothermia. We want to prognosticate. Now, getting MRIs done in our unit is fine. We have been doing it off and on. But with inotropes, is there any compatible syringe pumps or infusion devices, you think?
Right, sir.
Mhm.
So we have everything available. All infusion pumps, syringes, they're all MR compatible and available. We do at least adults also. They also require. They are also on inotropes. They also require. Those all can be actually imaged in the MR. They undergo MR if it is required. It's just that you connect them to monitors. You do a monitoring. Put your MR compatible monitors also, and you do monitoring. So all those are practically possible. It's just that during the process, when the child is there inside 10 minutes, 15 minutes, the chances of SpO2 going down or complications occurring increase. So that's always a trade-off which is required. But all infrastructure is available to get done.
There are many
So
questions.
this terminology
yeah.
terminology of pseudo normalization of MRI, HI.
Yeah, Dr. Ashish.
Right, sir. So that terminology is used for diffusion weighted imaging. So as I've told you, basically it's the diffusion restriction which starts occurring as early as few minutes after the cytotoxic edema sets in. Right. It gradually increases over a period of time and maximizes by 48 to 72 hours when the diffusion restriction is at the peak of it. Then after that, the diffusion restriction plateaus till around 5 to 6 days and then starts to decrease. Once it starts to decrease, the diffusion restriction is not evident anymore and the T2 signal of the diffusion weighted image becomes bright. At that point of time, you may not be able to identify the pathology pretty well, and it's known as a pseudo normalization. It's typically seen between 7 to 10 days post insult, post acute insult.
Thank you, sir.
Malhotra is asking, sorry, Mangla, one question from the audience here. He wanted to know something about GRE images for calcification and whether if yeah, that is something I have not heard of. What are GRE images for calcification?
Right, sir. Whatever I was showing you, the susceptibility weighted images, they are also known as GRE images, gradient recoiled echo images. Whatever I showed you for bleeds, I predominantly showed for bleeds. Those are the same set of images which are used for calcification. I'll just tell you the basic premise behind that is the whatever substance is paramagnetic will show some inhomogeneities on in MR fields and it will give rise to a signal loss. Paramagnetic substances will not produce any signal on MRI. So they will uh, give a signal void. They will appear absolutely dark. So the bleed has iron 2 plus, which is paramagnetic. Calcium has calcium 2 plus, which is also paramagnetic. So both of these will give rise to a signal loss on the GRE sequences. Whatever examples I showed you had dark signals on the susceptibility weighted or the GRE sequences. I was showing you examples of bleed. Similarly, the calcifications will also appear exactly like that on the GRE sequences. Whether it is calcification or bleed, that we will resolve by the basis of the clinical scenario. It is acute presentation, ventricle के अंदर है तो bleed होगा. Margins पे मेरे को दिख रहा है, periventricular दिख रहा है, वो मैं calcification मान के चलूंगा. ट्यूमर के अंदर है, bleed भी हो सकता है, calcification भी हो सकता है. Those things I'll need to see. There are different ways in MR which we can differentiate calcification and bleed also, but those are complex, still research oriented only, and practically sometimes useful, sometimes not. If you are having doubt, we go back and do a CT scan. If it was acute hemorrhage, we will detect it. If it is chronic and if it was appearing dark on susceptibility weighted, it has to be a bleed because the bleed, chronic bleed will not be seen bright on CT, whereas a calcification will continue to remain bright on CT irrespective of the time. Once it calcifies, it will remain calcified till the end of life.
Mangla, you wanted to ask something?
Yes, sir, I think we discussed a lot about the timing of a scan in HIE. So we'd like to have your opinion about the ideal timing in the other two common forms of injury, what we see, hypoglycemic brain injury, especially because that's an area where it's always difficult to exactly identify the timing of insult also, unlike HIE. It could have happened in any time. So if you're suspecting a hypoglycemic injury, what will be the right time, sir, to do a scan to pick up the injury?
So again, the timing of ischemic insults in MRI brain can only be done limited to whether it is showing diffusion restriction or not. If it is showing diffusion restriction, you know that this was within last 7 days. That's it. Sometimes extendable up to 10 days, but predominantly in the last 7 days. If it is not showing diffusion restriction and if it has started showing volume loss and cephalomyelitic changes, then you cannot time it. It could have been more than 10 days, 15 days, 1 month, 3 months, 6 months, 1 year, 2 year, 5 years, 10 years. I cannot time that on MRI, right? So if you want to time, if you want to know what was the event, if you're suspecting an acute event, get a MR done with diffusion weighted sequences after 2 days, 3 days of that insult which you are of the episode which the child has, then you can sure that this particular episode led on to this. If the episode was 10 days ago, then you are not sure whether it was that episode or it was an earlier episode not in front of you in a different hospital when the child came to you. You cannot time that. In bleeds, there's a longer time which is available to us because bleeds evolve over a period of time, more over 15 days, 20 days, 2 months. You can still time them over a period of time. But ischemia, non-bleed ischemia, just those days are required. You cannot time it more. Again, if you know by let's say a germinal matrix bleed I'm seeing later on in life, you've done the MR at 2 months of age. But if I'm seeing a germinal matrix bleed, I know that the insult occurred before 34 weeks of gestational age. So I know that by timing, because the germinal matrix will not be there after 34 weeks. So if the child was born at 37, 38 weeks in the perinatal period, if you're suspecting that the bleed occurred at that time or the hypoxic injury occurred at that time, but I'm not seeing any evidence of that, but I'm just seeing a germinal matrix, you can tell that this did not happen at this time. This was something which was an intranatal event and antenatal event, sorry, at the time earlier. That you can time, but not for a hypoglycemic insult unless you're doing it in the acute phase.
Okay.
Wonderful. Do you have time for a couple of questions more, Dr. Ashish?
There is a question from the audience with the
That's why I
PVL and
said,
early leukodystrophy. Can we ask that?
It is a question Dr. Asta Agarwal is asking. How do you differentiate PVL and initial leukodystrophy?
So by initial leukodystrophy, I think she's talking about the metabolic disorders, the leukodystrophies, right? PVL in the acute stages only will show some abnormal hyperintensity, just pure hyperintensity, which is best seen as ultrasound PVL, periventricular flares on ultrasound. The moment it goes to a stage of formation of cysts and volume loss, which quickly occurs over a period of few days itself, it will lead to a volume loss, significant volume loss. And any PVL over a period of 7-10 days or more would ultimately have a significant volume loss associated with it. And the hyperintensity will more or less will not be seen because there is a volume loss occurring. Leukodystrophy will have volume loss only in a burnt out stage, very burnt out stage, right? Again, so the leukodystrophy has a much longer period. Like let's say we talk about Canavan's or a metachromatic leukodystrophy or megalencephalic leukodystrophy or the Venter-Knapp disease. It will have white matter hyperintensity, diffuse white matter hyperintensity over a period of months and months together, then leading on to a volume loss. Leukodystrophies will not present in the neonatal age group, very early neonatal age group. I hardly see a proper leukodystrophy presenting that early in the first month of life. They usually take time to present. PVL again will be seen that acute stage when it is just bright without a volume loss, appearing like it is more like a DESI pattern, which is diffuse, excessive, high signal intensity. I'm sure you guys know it better than me. It is also a pattern which has been described, but it is again generalized hyperintensity for the initial few days itself. You cannot, you will have to depend upon the clinical scenario. If it was an acute insult and then behaving like a static insult sequelae, and the MR over a period of time showing you volume loss, it was a HI. But if it is a progressive type of a disorder with regression of milestones and the MR continuously showing you increasing, then it is a leukodystrophy type of a.
I think that is great. Amit, can we wrap it up now? I think that's the end of it.
Yeah. I
Thank you
think
so
we
much,
should.
Professor Atin. It was wonderful. Thank you.
Thank you, sir.
Thank you, Ashish, and thank you, Amit, for this wonderful
It
session.
was really eye-opening.
It was wonderful. And
Thank you, Atin.
Dr. Bish, thank you so much.
Thank you, sir. Thank you, Ashish.
Thank you, everybody.
Thank you, Dr. Nitin, thank you, Dr. Manjari, and Dr. Karthik and Dr. Mangal Bharti. Thank you. I think
Bye,
Gagar.
Mangla.
Thanks, everyone.
I could not say hi to you. Bye.
Thank you. Bye.
Bye,
Bye-bye.
sir. Good night.
It was wonderful. Thank you.
Atin, see you. Atin, party है कि नहीं है? Are we meeting?
सर जब बोलो तब मिल लेंगे.
Chalo.
Dr.
Okay.
Surinder and me go have a long association.
Long is we are family. We are a family.
Like a family actually.
Very nice.
Bye. Bye.
Bye.
Bye.
Bye-bye. Thank you.